My name is Scott Murdy with Kraft Healthcare Consulting, which is an affiliate of Kraft CPAs. We are based here in Nashville, Tennessee. And as many of you know, Kraft CPAs is a traditional CPA firm providing audit, tax, and general accounting services, as well as a variety of advisory services, including those to the healthcare industry. Within the healthcare industry, we do a number of things from accounting and tax and audit work specifically for healthcare providers, as well as other items involving the revenue cycle and reimbursement and compliance. I'm going to introduce Stacey here in a minute, but I do want to let everyone know there is a Q&A function and a chat function at the bottom of your screen. I'll be monitoring those throughout the presentation, and if appropriate, I will chime in and see if Stacey can answer that. Otherwise, we will try and address all of those questions at the end of her presentation. Many of you know Stacey or have worked with her in the past. Stacey has a number of years experience within the healthcare industry. She will get mad at me if I tell you exactly how many number of years, so I'll just leave it at that. And as you can see, she has an alphabet of credentials behind her name. She is a certified medical practice executive through the MGMA, as well as she holds a number of credentials through the AAPC and is also a certified HIPAA compliance officer through the American Institute of Healthcare Compliance. In addition to doing these types of presentations, the Healthcare Helpings, which is something I failed to mention, we do this quarterly here at Kraft, and generally they're in person, we host here, but obviously we have been doing these virtually the past year, and hopefully we can get back to doing these in person here soon. Stacey has also written a number of articles involving compliance and coding, clinical documentation, and she's going to speak to us today on the 2021 Physician Fee Schedule that has recently been implemented. So with that, I will turn it over to Stacey. Thank you.
Good morning, everybody. I hope you guys are doing well. I'm going to get this out of the way really quickly. Here's just the disclaimer. This is not a legal or consulting opinion. It's educational only, and it was up to date at the time it was created, and hopefully that's still the case. But if there are any questions, like Scott said, you can type them in, and hopefully I will have time at the end of the presentation to answer them. But if I don't, I will respond via email to anybody's questions that didn't get addressed. Also, I wanted to let you know that today's presentation is going to be on the 2021 fee schedule, but it's going to specifically more so target the anticipated impact of that fee schedule. So I am going to jump right in because I have a lot of slides, and hopefully I'm going to go through them semi-quickly, so hopefully we have time for questions. But again, if we don't, I will address those via email afterwards. You guys will also be sent a copy of the presentation afterwards. And with that, I'm going to jump right in. First thing we're going to talk about is the structure and the timeline of the Medicare fee schedule. A lot of you guys are familiar with the structure, so I'm going to go over the basics fairly quickly, but I do want to address them for those of you who may not be. This year's timeline was a little bit different in that there were some things that happened at the end of the year that had a major impact. But basically on August 3rd, the proposed rule came out, and anytime when the proposed rule comes out, they leave time for public comment. That time was closed on October 1st. And then on December 1st, the final rule was released that would become effective January 1st of 2021. However, Congress came in on December 21st, and they had they enacted the Consolidated Appropriations Act, and they signed it into law on December 27th. And I'll tell you how that affects us, or the Medicare fee schedule, in just a few minutes. The Medicare Physician Fee Schedule, RBRVS system. What this means is, and most of you already know this, it's a resource-based relative value scale, or you hear it referred to as RBRVS, is a physician payment system used by CMS and some other payers. The RBRVS system is based on the belief that payments for physician services should fluctuate depending on the cost of the resources involved in providing the service. For example, it's going to cost people or physicians in Nashville different, and the resources used are going to be different than it would somewhere else in the country, say New York or whatever. The RBRVS system is based on 3 criteria: the physician work, practice expense, and malpractice expense. The physician work component accounts for an average of 51% of the total relative value for each service. It measures the time and effort required by the provider to deliver the service, the technical skill, physical effort. The practice expense component accounts for an average of 45% and basically measures the cost associated with the performance of the procedure. And last but not least, you have the malpractice or professional liability insurance component, which accounts for an average of 4%. And this considers the risk factors. Each type of RVU is added together and then multiplied by a geographic practice cost index. A lot of you guys know this, you hear GIPSY. Well, that's what that is. And that refers to what I mentioned a few minutes ago, where the resource and the cost are different based on the areas that you live in. And so that's taken into effect, or into an account, I should say. The next slide just shows you the formula that's used. It attempts to assign a value for each CPT code based on how resources are utilized for that particular procedure: the consumption of the doctor's time and effort to perform the work, the expenses consumed to do the particular procedure, and the probability of malpractice exposure. It's a lot of long numbers, but we're going to specifically talk about this conversion factor in just a minute and what that is, because that's where that CAA came in and affected us. Why did the AMA change RVUs and guidelines for E&M codes? They wanted to reduce documentation and overload and provide physicians the opportunity to spend more time with patients than completing paperwork. Physicians continually voiced concerns that there were so many documentation requirements that it was taking them away from simply taking care of the patients. This is all a part of the Patients Over Paperwork Initiative. I'm sorry, I can't speak this morning. CMS and AMA wanted to reduce paperwork and streamline coding and documentation by making it clinically relevant. And those are 2 key words: clinically relevant, because what they were seeing was a lot of note bloat where things came over from one note to the next, and sometimes it wasn't clinically relevant to that visit. Between July 2018 and 2019, AMA worked with CMS and a lot of the specialty societies and other healthcare professionals in order to come up with the guidelines that just became effective January 1st. The recognition of added physician responsibilities, like we just talked about, the EMR documentation, patient status documentation, care coordination when that was not billed separately. Okay, when Medicare makes a change to the Medicare conversion factor or the fee schedule, it has to be, anytime a change is made, CMS has a policy that requires it to remain budget neutral. In order to make that happen, the conversion factor that was released initially in that December 1st final rule was $32.41, which was a $3.68 decrease from the prior year conversion factor of $36.09. And again, most of you know what this is, but I'm going to talk about it anyway. The conversion factor is the national dollar amount assigned to a relative value unit. The conversion factor is used to convert the RVU to allowable fee amounts. I just like this cartoon because it's an old one, but it's especially applicable this year. No, Congress has given you a 2-month doc fix extension. Basically, what they did is they signed the CAA. When the CAA, or the Consolidated Appropriations Act, was signed into law on December 27th, it provided a 3.75 increase to the conversion factor that they had previously published of $32.41. So now the 2021 conversion factor went from $32.41 to $34.89. The CAA relief bill included billions of dollars for COVID-19 testing, vaccine administration, and this relief for healthcare providers, in addition to the increase of the conversion factor. One of the important things, the reason they were doing that, and I mentioned that budget neutrality, was there was a HCPC G2211 that was created CMS created as an add-on code for the complexity inherent to an E&M visits. Well, what they did is they put the CAA called for a 3-year suspension for payments of that code. So through December 2023, G2211 won't be used, and which accounted for 3% or $3 billion of Medicare spending money. But what's interesting about this is this code, this G2211, it's still reflected in the CMS OPPS Addendum B as an active code with a status indicator in. So bottom line, that code's still out there, but it's a bundled code right now. It's saying it's included in the E&M services through December of 2023. But by doing this, putting this on hold, they could still stay budget neutral and increase the conversion factor. This slide represents the past 6 years of the conversion factor rates. As you can see, it's slightly increased from 2016 to 2020. If you look, we're at 2020, we're at 3609, but in 2016, we're at 3580. Then in 2021, it's still a decrease, but after the CAA was signed, it became 3489, which was $1.20 more. Or I should say, it's still $1.20 under the 2016 rate. If you look at this slide, what I did is I went on CMS's website and I got utilization rates, because according to CMS, codes 99201 through 99215 account for 40% of all reported CPT codes and 20% of the revenue. So when you look at this, what changed was the work portion of the RVU, the physician work. So if you look, the 2020 work RVU for, let's say, 99203 was 1.42. Well, they increased that by 0.18. In 2021, it's 1.6. The biggest increase was established patient, 99215. The work RVU in 2020 was 2.11, but in 2021, it's 2.8, which represents a 0.39. You got a pretty big bump on 205 as well. And then that last column, again, just represents the 2019 utilization of these codes, which you can see is pretty significant. I think it totals up to like 248 million times it was billed, something to that effect. And these bumps in these RVUs, you're going to see how that ties into money in just a minute, or revenue, I should say. As discussed, it's important to remember that all the changes in the Medicare fee schedule have to be budget neutral. So if RVUs for E&Ms are going up, then the money to pay for that must come from somewhere else. And like all budget neutral changes, there's going to be winners and there's going to be losers. The anticipated impact ranges anywhere from a negative 10% to 16%. And the next slide is going to show you, I pulled this from the final rule that was posted on December 28th, 2020, after the CAA was signed. So if you look at this, this tells you what Medicare thinks the anticipated impact by specialty is going to be. So the first column is positive. You can see endocrinology, rheumatology, you got 16% increase, 15% increase, hematology, oncology, 14%, internal meds, 4%, peds is 6%. And then in the middle, you've got cardiology, clinical social workers, pulmonary disease, clinical psychologists. They're saying, we think they're going to be pretty much stay the same or be neutral. But look at the negative column. And the thing that they have in common, a lot of them, is not only do they see patients in a office setting, but they see a lot of their patients in a facility setting. Radiology is a negative 10%. Emergency medicine is a negative 6%. Critical care, a negative 7%. Anesthesiology. So you can see it's from one end of the spectrum to the other. I got a question prior to the webinar that was asking about the blended rates. And I'm going to go over this slide in just one second, but I had a question that was asking about the blended rates. In 2019, the final Medicare fee schedule had a plan to pay a single rate for E&M visit levels 2 through 4, starting in January 1st, 2021. They put it out in 2019 and said, okay, we're going to give you a blended rate. Medicare intended to pay the same rate regardless of which code was reported for those levels 2 through 4 visits. But then they came back and said, okay, we're not going to do this. Even though it was in the final rule, we're not going to do this. We're going to stay with a fee structure like we always have in the past. And that's what you see on this slide. And let me preface, this slide is for participating providers in Tennessee in a non-facility setting. So you can see in 2020, everything, not all your new patient and established patient codes. But if you look at 99215, it was bumped up by $32.24. 202 lost $3. 211, which is basically your nurse visits, is 49 cents. So not a big change. But if you look at those established patients visits, 212, 213, 4, and 5, those are some pretty significant bumps in the rates. And if you think back to that, if you think back to this, the utilization, that makes a big difference when you're talking about, okay, 10 million visits are increasing by $32 a visit. That adds up. All of this, is stemming obviously around the 2021 evaluation and management changes. The E&M services, you're going to see a net payment increase due to the raise in the RVUs, which I just showed you. And then the changes for, this is really, really important. Changes are for CPT codes 99202 to 99215 only. Requirements for all the other codes remain the same. And I've got a table later on in this presentation I'm going to show you, because like general surgeons, anybody, any specialty that orthopedics, peds, any specialty that sees patients both in office and in the hospital will have to go under 2 separate guidelines. The new ones versus the 95, 97 old guidelines that have been in effect for over 20 years. So it's really important that you pay attention to that. 99201 was deleted. AMA and CMS both agreed that if you have a new patient come in the office, there's going to be some kind of medical decision making involved. So they reference and they tell you to look at 99202. The new guidelines, the code levels are based on medical decision making or time. History and exam are not counted in the selection of service. We're going to talk about history and exam just a minute or two later on, because there's some things I want to point out about that. Prolonged services are used for 205 and 215, only your highest level of patients. And there's 2 codes out there for that. The provider must communicate his thought processes in his documentation. From the aspect of medical necessity, the correct level of service is determined by how sick the patient is. The provider can usually tell by the nature of the presenting problems what level of E&M should be billed. But if he doesn't document that, or we don't understand how sick that patient is, then the right code may not be chosen, and that has an effect. Condition posing a immediate threat to life or limb qualify for the highest levels, where patients whose condition reflect minor or well-controlled or problems at the lowest. Bottom line, the volume of documentation should not be the primary influence upon which a specific level of service is billed. That documentation has to tell a story, and it is all about the view of the patient, the problem, and the risk involved. Here's what it looked like in 2020. We had history, exam, presenting problem, and medical decision making or time. And when you did time, it was face-to-face only, and it had to be greater than 50% counseling and or coordination of care. Here's what it looks like in 2021. You've got a medically appropriate history and or exam plus medical decision making or total time the day of the encounter. And it does not all have to be face-to-face, and the greater than 50% does not apply. History and exam. I've gotten a lot of questions about this. Here's what changed. It says office or other outpatient services include a medically appropriate history or physical exam when performed. Healthcare providers shouldn't interpret this change to mean the documentation of the history and exam is not necessary. A clear statement of any history and exam work involved will remain an essential part of the medical record. It supports the complexity of the patient. There's not a documentation change. It just means that this won't be used when we're selecting or choosing a code. But if a person has, diabetes or COPD or chronic heart, any chronic kidney disease, when you're prescribing medications or when they're thinking about it, if that's not in there, then I don't know that as an auditor, or CMS doesn't know that or auditor, but that physician thought about that and says, well, can I prescribe this medication or that medication? Or like in an orthopedic office, if somebody is getting injections and they're diabetic, I'm sure that physician goes, okay, steroids, diabetes, let me think about this. That was part of that thought process. So it's really important that that stuff still be documented. The big talk about all of this is there was not a definition. CMS came out and published a ton of definitions, what an independent historian was, test, all of these things, but they did not publish a definition for medically appropriate. So bottom line, the physician or the healthcare provider just needs to ask themselves, if there's not an HPI, will they be able to support the medical complexity associated with the encounter? And again, that's for a number of reasons, not just for the selection of the code. That can come into play for malpractice, all of that. The documentation requirements are the same. I can't stress that enough. It's just the H&P and exam are not a part of choosing the code level anymore. Here's that table I referenced earlier. If you look at the first column, it says, okay, here's all the components. The second column shows you the what's needed for 202 through 215 under the new 2021 guidelines. The third column shows you, it says, okay, all these other E&M services, observation, hospital, inpatient consults, ER, nursing home visits, all of those things, they still stay the same. You still use the key components for those, the history, exam, the MDM. Look at the difference in time between 2021 and prior. 2021 is total time on the date of the encounter. Prior to that, again, it's, it had to be, it includes both that face-to-face and non-face-to-face time. So there's just a difference in that. So you need to be cognizant. You need to be aware. Here's one of the new prolonged services codes that I talked about. I highlighted this because look at the beyond the minimum prolonged service code for outpatient E&M services beyond the minimum of required time. That's important, and I'm going to show you why. Here's the next prolonged services code. This is a Hex Fix Code that's supposed to be used with Medicare. It says beyond the maximum. This is it's contradictory in nature, but it's causing a lot of questions. And we really expect further guidance to come out on this. But look at this table on the next slide. AMA and CPT Code Descriptions for 99417 says, okay, if you can bill 99417 in addition to the 205 for the new patient, it's 75 minutes. But if it's a Medicare patient, you can't bill it. It's less than 89 minutes. It's not billable. If it's 89 to 103, then you can add it. But for non-Medicare patients, it's 75 to 89 minutes. So again, this is where CMS and AMA are not on the same page, but this is what we've got to work with right now. This is for the new patient, and this is for the established. So I just wanted to point that out so that everybody can see. It's really, one adds it to the top and one adds it to the bottom. So let's talk about the allowables, CPT code allowables. I think we've got a pretty good mix of folks on here from different specialties. But if you look, what I did was I looked at Medicare Part B's national data for 2019, 2020 was not available. And this is by specialty for CPT code 99214. And it was the most utilized codes of all CPT codes in 2019. So if you look at this, here, the first is the specialty. The second shows the number of allowed services or the utilization. Then 2020 based on non-facility, here was the allowable for 214. And then 2021, the allowable is 122.31. And then here's the difference. Look at the for family practice, 367 million. Look at the internal med, cardiology. And now here's the thing. I got to remind you that people that have a heavy work comp, this is not going to affect, it's not going to affect your work comp cases. So we'll talk about reporting and what to look at later on, but you should be aware that obviously this has nothing to do with work comp. This utilization is strictly for your other case mixes and how it affects them, because your fee schedules for your commercial carriers and the way they work is a lot of times they're based on the Medicare allowable, but that's not the case with work comp. So anyway, you can see one code makes a huge difference. It can make a huge difference. I looked at some other common CPT codes. And just by for derm, the first one is that incision and drainage. A lot of surgical practice, dermatology use those first three codes. And then we've got hip replacement, knee replacement. Look, see, they got hit. Knees and hips went down about $90 per case. Colonoscopies, gallbladder. So again, you saw on that slide I showed you where those specialties were earlier. General surgery, you can see that in some of these where those surgical, they took money away, whereas you got a little bump on those others up there. Here's a couple more that we've got. Looks like delivering a baby, those went up some. Cataract surgeries went down by almost $11. Chest x-ray, just for the read, because a lot of physicians will charge for that. Mammograms went down. Again, that takes into account for those radiology codes that, I think we saw negative 10% for radiology. And that's all I'm going to talk about as far as the allowables and stuff. I'm going to move ahead now and talk about a little bit about telehealth, because there was quite a bit of telehealth changes. So let's talk about that pretty quickly. Telehealth in 2021 policy changes. Prior to the changes, there was no incident 2 in telehealth. Direct supervision, now with the changes, direct supervision can be provided using real-time interactive audio video technology for the duration of the PHE. The final rule included both policy changes as well as a list of new services covered under Medicare. what it did is it opened up opportunities for telehealth and incident to billing. CMS acknowledged that there was no Medicare regulation that explicitly prohibited eligible distant site practitioners from billing for telehealth services provided incident to their services. Boy, that's a mouthful to say. But anyway, because of the current definition of direct supervision, which required on-site presence of the billing clinician when the service was provided, it was difficult for a billing clinician to fulfill direct supervision services provided via telehealth incident to their professional services. So under the new definition, CMS clarified that services can be provided incident to via telehealth under the direct supervision of the billing and practitioner via virtual presence. What has to happen, again, is direct supervision is met if the supervising physician is immediately available to engage via interactive audio and video. It's important to note that this is not audio only, is not sufficient. And this change is limited until the PHE ends, like the year that the PHE ends, because they're worried that it may not be safe. So they're still looking at this. And then they created a code G2252 to be used for the duration of 2021 for extended services delivered via synchronous communication technology, included audio only. This is those virtual check-ins. The service is considered a communication technology-based service and is subject to all the CTBS requirements. Again, this G2252, it should be noted, and remember, this is for an established patient. And it can't lead to a E&M service, or it can't be as a result of an E&M service that was provided 7 days before, or scheduling an E&M service. If you schedule an E&M service within 24 hours or the next soonest available appointment. Communication technology-based services, the CMS requirements. When a brief CTBS originates from a related E&M service that, like I just talked about, and a service is provided within previous 7 days of the same, then it's considered billable in the E&M service. But if you do bill that, you have to get consent, because the purpose of the consent is to notify the patient they may get a bill for copay. You can't waive that. So the consent can be verbal or written, and it has to be documented by the billing practitioner or auxiliary staff under general supervision. Again, consent must be documented. Then there's codes for therapists. G2061 through 2063 may be billed by licensed clinical social workers, clinical psychologists, physical therapists, OT, speech and language pathologists, and other non-physician practitioners who bill Medicare directly for their services when they bill within their scope of service. Again, this is a temporarily allowed under the PHE waivers, but now the new rule is permanent. It was allowed temporarily, but now it's permanent as of January 1st, 2021. And then it's just telling you to use your same GO, GP, or GN therapy modifiers. $2250 and 2251, these codes are equal to the reimbursement for 2010 and 2012, which are those virtual check-in codes that are billed by physicians. So these are saying, for those that can't bill E&M, here's 2 new G codes that were set up for you to be able to use for the remote assessment of recorded video and images that store and forward. And then the 2251 is the virtual check-in. So like, the first one is somebody sends you a picture of a rash or, through the patient portal or whatever, and you look at it and you say, oh, I don't need to see them, blah, blah, blah. Put some ointment on it and may the force be with you. No, I don't mean like that, but it doesn't result in an E&M. New frequency limits for telehealth and nursing facilities. CMS reduced the frequency limitation for coverage of subsequent nursing facility care that's furnished via telehealth from once every 30 days to every 14 days. These limitations were temporarily waived, but they were made permanent again January 1st. CMS did not make changes to telehealth frequency limitations for hospital inpatient visits and critical care consultations. Those stay the same. Telehealth codes are typically in one of three categories. Category one are codes that they say, okay, they can be telehealth codes. We're comfortable. They're codes that are slated to remain in place. Then they'll put codes in what's called category two, and they'll say, okay, we're going to put them here temporarily because basically they're going to be scheduled for elimination. We know they're not long term. And then there's a category three where these services, they don't have enough clinical data yet to decide if there are clinical evidence, I should say, to evaluate if they should become permanent under a category one, or if they should be eliminated under a category two criteria. So they're sitting out. Category three is basically a yet to be determined. So for 2021, CMS finalized the addition of 60 new category one telehealth services that will be reimbursed and become permanent under Medicare effective January 1st. So they got all the data together and they said, okay, yeah, these are good. We're going to keep them. Here's the coverage. They expanded it to group psychotherapy, physiological and neuropsychological testing, rest home custodial care services for established patients. What's interesting about these codes, you see that 99334 and 335, those are the straightforward and low MDM, and they're now put on a category one list. But 99334 and 99337, all those CPT codes represent established patient domiciliary rest home, and custodial care. So those first two, they have straightforward and low. But we're going to see in a minute that 336 and 337, they're on the category three list, which means they're saying, we don't have enough evidence to make them permanent yet. We're going to put them out there, but we don't have enough to make them permanent yet. Moving down the list, you've got a cognitive assessment and care planning services, visit complexity inherent to certain office. Okay, that's that code, that G2211, that is an active code, but it's with that status indicator that says it's bundled into the E&M. So you can still bill it, you're just not going to get paid for it, but it is a permanent telehealth code. And then you've got that prolonged services code that we talked about, the G2212. Here's category three. These codes are added to the telehealth list during the public health emergency for COVID-19, and they'll remain on the list through the calendar year in which the PHE ends. Again, and at that time, these category three codes, they'll look at the clinical evidence and they'll say, okay, this is either going to become a category one or a category two. We're just eliminating it because it shouldn't be a telehealth code. See, there's that 336 and 337 that I was telling you about that have the higher levels. They're considered category three. Then you've got home visits, ED department emergency visit levels 1 through 5, the 281 through 285, nursing facilities, psychologic and neuropsychologic testing, and then therapy services for PT and OT, all levels. Hospital discharge, right now you can do that via telehealth, but it's that category three. Don't know if they're going to leave it there. Inpatient neonatal, pediatric, critical care, subsequent critical care services, end-stage renal disease, monthly capitation payment codes, subsequent observation and observation discharge day management. So, okay, I went through all of this stuff, and it is by no means a comprehensive discussion on the 2021 fee schedule. I wanted to really talk about the things that affected compliance the most. I shouldn't say it like that, but I picked out 2 things that I thought I really wanted to address in depth. So what do I do now? You need to review your practice procedures and protocols to ensure they're consistent with the new guidelines. You know, between AMA time versus CPT time for the prolonged services, between your utilization rates, you know, by now patterns should start to emerge with regard to a provider's E&M utilization and documentation. You know, as EHR templates change and providers make the choice between basing their E&M level selection on medical decision making or total time, and maybe they're going back and forth between both, practice should notice something of a normalized pattern that reveals itself with regard to the timely completion of documentation. You know, I'm sure you've all done this, but confirm with that EHR vendor that they've implemented the 2021 E&M visit code changes correctly. Because, you know, especially for those practices that are not only using 22, it's important for all, but especially for those that are using both sets of guidelines, the 2021 and the 1995-97. And, you know, number 3, this comes from my background. I'm a revenue cycle person at heart, and I can't tell you, this may not seem like it ties into this, but it goes back to talking about those patterns and the things you see. If you're consistently monitoring your KPIs, your key performance indicators like days in AR, aging report by payer, your collection rate, your clean claim rate, all of that, those things all add up to saying, okay, is this quarter any different? Is the first quarter of 2021 any different than the last quarter of 2020? Because if you look at your last quarter, analyzing the data from the past quarter, it'll give you a baseline that reflects where your practice stood prior to these changes going into effect. And once that data is analyzed, you need to pay attention. Again, I keep going back to the patterns or things that stick out. Didn't have this last quarter, but I got it now. Or what is this? If a provider has a sudden downswing or upswing in utilization, those really need to be audited and analyzed to make sure that they're compliant with the guidelines, that there's nothing weird or goofy going on. Need to make sure that claims are not getting hung up in the EHR system or clearinghouse due to any changes made in the EHR system. I mean, when you make a template change, that really doesn't have anything to do with, you know, when the claim goes out for billing. But, you know, if there's a rule or there is something set up with the clearinghouse, it could hang up. And that there again, that's why it's so important to look at this. Data analysis is really one part of a multi-step approach that you need to have in your practice, especially with this new normal of these guidelines. I can't stress how important that is. I just mentioned utilization. Perform a CPT Code utilization analysis. Most practice management systems have a report built in. They'll give you a detailed list of information for the specific CPT codes for a specific date range. So if you run a report that says, okay, let me look at last quarter and compare it to this quarter. And depending on the specialty, the E&M code range represents a significant amount of the total bill services. As we talked, I think we said 20% of the revenue and 40% of the volume is what CMS has came out and said. So for specialties that E&M don't represent a significant number of billing, it's still important to analyze that because of those RVU changes. You need to know what represents both the dollar amounts and the volumes. Obviously, I am in no way telling you to code based on revenue, but I am telling you to code accurately and be compliant and get the most money you can get based on the services you provide. You certainly don't want to overcode by any stretch of the imagination, but you don't want to leave anything on the table either. And, you know, by doing all this analyzation, it's going to tell you if, you know, you should anticipate an increase or a decrease in your expected revenue. And as a person who worked in physician practices for a long, long time and in hospitals, you know, whether it's a CFO coming to you going, where's the money, or the physician going, you know, why is my revenue up or down or whatever, you can answer those questions. This is really important. Perform a baseline documentation and compliance audit for E&M codes ranges. It's important to remember that depending on providers, I've said this a number of times, they can be using two sets of guidelines. And, you know, whether you've got a provider that's using MDM or time or switching back and forth, you need to make sure they're choosing the appropriate level. I've been on a lot of conference calls and webinars, and one of the things that they talk about is impossible day audits, where it means they're going to look at it's data mining. They're going to look at patterns in data and see if the documentation supports the codes, and yet you're looking at an impossible scenario, meaning an individual provider has documented more than 24 hours of face-to-face time with individual patients on a given day. So, you know, you've got to make sure, whether it's time or MDM, that you are compliant and doing this correctly. The financial impact of over and under coding it can't be overstated. It's estimated that E&M codes represent, I just said that, 40% of total revenue on the average. Auditing and denial monitoring is vitally important to ensure no revenue is being left on the table, or that you're not, and as equally important to this is not only are you not leaving anything on the table, but you are doing it according to guideline and you're being compliant, because in the words of my grandfather, you don't want to be penny wise and dollar dumb, meaning you leave yourself open for the OIG or Medicare to come in and say, okay, I'm going to review all these, and guess what? They don't meet the level and we want all this money back. So that brings me to my next slide. You know, are you ready for these changes? Major changes have been made to the E&M codes for the first time in 20 years. Are you prepared for that? You know, here at Kraft, we can help. We have a package, sort of, for lack of a better word, where we will review up to 5 records per provider for compliance and documentation purposes. And then depending on what we find, we can customize training to your practice or facility for those positions involved. So it's not just a canned training or provider education kind of deal. If we look at your records and we have findings, then we can target areas that we know you need help. So don't hesitate to contact us about that. We'd love to help you. Again, I mentioned this earlier. Don't be caught off guard by or at risk from a potential Medicare OIG audit. Our healthcare team also, not only in addition to the provider education, we assist with HHS, Provider Relief Fund reporting, HIPAA, high-tech, high-trust compliance. You know, again, Scott mentioned it, revenue cycle items, coding and documentation audits, Medicare, Medicaid cost reports, RAC appeals, risk adjustments. We've got a lady that lives to argue with ALJ judges. That's just one of the things she loves most. So hopefully this has been extremely helpful. Here's my name, my email address, my telephone number. If you have any questions, please don't hesitate to reach out.